Wanted to welcome everybody as we're getting some people joining in. Hi, friends and colleagues. My name is Andy Hollowell. I'm the Chief Growth Officer here with Lightfully Behavioral Health. And I wanted to welcome you all to what is going to be part 2 of our educational discussion on suicidality. Beyond the Crisis, Innovative Interventions for Chronic Suicidality. Now, before we get things kicked off, I wanted to give you just a quick overview of Lightfully's services and a few exciting announcements that we have. So, as most of you know, our mission here at Lightfully is to change lives compassionately. And part of the way that we do that is in providing primary mental health services to adults 18 and up, and then also to teens ages 12 to 17. We are also a gender inclusive program, so you will find that we accept clients of all genders at each one of our programs. We are located down in San Diego, in the Los Angeles area, up in Thousand Oaks, where I'm sitting today. And we've just recently launched programming up in Northern California in both Redwood City and San Jose. So our primary goal is, of course, to be as accessible as possible as a treatment provider. And we do this through insurance contracting, providing a vast array of locations, and then lastly, providing clinical excellence. So in our latest and greatest news, I wanted to just share, as I mentioned, we just opened programming up in San Jose and Redwood City. So we have a teen residential program up in Redwood City. We also have both adult and teen programming at the PHP and IOP levels of care in our San Jose location. Additionally, we've also recently launched Lightfully You, which is a virtual IOP program specifically tailored to college students. And we're really excited. I know that, waiting around for a college therapist and to get a session sometimes is very, very lengthy process. So we're really looking forward to treating more and more college students as their needs pop up. So lastly, I just wanted to announce that we have expanded our contracting with Kaiser, which is really exciting in the Southern California markets. We have been in network with Kaiser at our Los Angeles location for some time, but are really, really excited to announce it now in San Diego and up in Thousand Oaks. Our programs will be a network for Kaiser clients. Lastly, of course, as we opened programming up in Northern California, we're working to get contracted as well with Kaiser in that area. So stay tuned for updates there. So getting back to our presentation today, I wanted to remind you that we did have a part 1 of this, which you didn't need to have watched before attending this one, but it is still available. So if you would like to watch that presentation, you can just email us and we will send you out the link for that. We'll be hosting these quarterly CEUs, so stay tuned for updates and what's to come next. But for now, I would like to introduce you to our speaker for today. So I wanted to introduce you to Dr. Nicole Siegfried. She is our Chief Clinical Officer here at Lightfully Behavioral Health. She's a licensed clinical psychologist and also serves as an adjunct assistant professor of psychology at the University of Alabama at Birmingham. She's worked in mental health treatment for over 20 years and has served in national leadership positions for the last 10. She is an international speaker and has published research, magazine articles, and book chapters on eating disorders, mental health, and suicide. Nicole believes that recovery is possible for all individuals with mental health disorders and that individuals are capable and deserving of a life worth living. So I love that, Nicole, and I'm so excited to hear your chat today. So without further ado, I am going to pass it over to you. One last reminder for our attendees today. So we are going to hold questions for the end of this call. Don't worry, we will get to those as soon as we wrap the presentation. But we have a couple sections. If you have general commentary, you can put those in the little chat box below. If you have a specific question or comment related to the content and want us to address those at the end of the session, please use the little Q&A bubble down below, and we will get to those at the end of the chat. So without further ado, Nicole, I'm going to hand it off to you.
Thank you. Well, welcome everyone. I'm really excited to be able to meet with you all today and to share this part two. That I always joke because I am overly ambitious in my presentations, and I always think I'll have time to get to some of this in the part one in terms of assessment and risk level intervention, and I never do. So I'm excited to now provide a webinar just on these interventions and working with those clients that may be frequent attempters, who may be high utilizers of mental health resources, treatment resources. And so I hope that today you'll be able to take back with you some tools for your toolbox in working with these clients. I also, at the end of the presentation, I will have a QR code, super fancy, so techie, I know, where you're going to be able to use your phone to click to get to all of the handouts and to the slide set. So you'll have access to all of this. All right, so I'm going to start sharing. So for our agenda for today, it's a pretty hefty agenda. So we'll be getting to a lot of juicy content. One thing I wanted to make sure I noted ahead of time is that around 12, we'll take a 5-minute bio break. So obviously, I know this goes over lunchtime for those of you on the West Coast. So get yourself some snacks or some lunch during that time as well. So we will take a break. I am now on the West Coast. You might hear in my voice that I have a Southern accent. I'm originally, well, I've lived in the South for the past 25 years, but my family and I just moved to Oregon last year. So now I am an official West Coaster. And so it's just beautiful here. We're in Bend, and so it's been snowing the last couple of days. And so I now can say I'm on Pacific time. So, but I've always worked with a company that's on Pacific time. So it feels good to be joining the ranks. All right, so today we're going to be going through first defining the challenge. Why, who are the clients that we're treating when we're talking about chronic suicidality, and what is the challenge in working with those clients? I'm then going to jump into foundational components of treatment when we're working with clients with chronic suicidality. Then I'll talk about treating chronic suicidality in general, and then we'll dig into addressing what we call suicide drivers. That will make more sense as we go. And then we'll have some time for takeaways and questions and answers. So let's first start with defining the challenge. So we're going to talk about some statistics, and then we're going to talk about whether or not there should be a diagnosis specific to suicidality. So let's start with some stats. So first of all, my approach in working with clients with suicidality and in training individuals to work with these clients is not to use scare tactics. Scare tactics don't work. When we're afraid of things, we tend to avoid them. And so we would then avoid training, which is the exact thing that we need. So when I share some of these stats, it is not to be scary. In fact, my hope is that through this presentation, you're going to leave feeling more confident, competent, and hopeful in working with these clients. I started working with clients with suicidality when I worked in eating disorders. And the reason I started specializing in it was because, whatever that saying is, necessity is the mother of invention. I felt really ill-equipped in working with these clients. I'd been trained, like many of you probably, that what to do in a crisis situation. And send someone to the hospital. How do you know if they need to go to the hospital? But that was really my intervention. And I kept finding that when clients came back, I sort of had this idea that'd be like, okay, the work was done at the hospital and you should be good to go now. Let's get down to work on your eating disorder. And obviously that's not what happened. And so what I was more likely to see is that the crisis had, they moved through the crisis, but they continued to be inundated with suicidal thoughts, desire to die. And I didn't know what to do with that. So I started working at that time with a suicidologist. I didn't even know what that term was, in learning as much as I could to start working with those clients. And so that was about 15 years ago. And so I'll be sharing some of that with you all today. So like I was saying, the suicidal behavior is the most encountered mental health emergency, and mental health providers rate it as the situation or the presentation that elicits the most fear for them. So this is what we're looking at. It's something that's frequent and we're afraid of it. And like I said before, often we tend to put our heads in the sand when we're afraid of something and just pretend like it doesn't exist. And so that keeps us from getting very valuable and needed training. So you all have worked through that because you're at this webinar today. So you've taken a good first step. 1 in 5 of us will lose a client to suicide. I've lost a client to suicide, and it, even when I just said it, I could feel my heart sort of sink. It was one of the most profoundly impactful events in my career. And I have been, trained to do this work and have really immersed myself in this work. And even with that, it impacted me just as much as anyone else. And I asked myself the same questions that everyone asks. What could I have done differently? And carried that with me. And so those of you who've gone through that and gone through that pain and loss, you're in that same club with me. And so it's not a club anyone wants to be a member of, but based on the work that we do and working with high risk individuals, it is something that will happen for many of us. The majority of us, if we haven't lost someone to suicide, we've had clients attempt suicide. 71 to 75% of us will have clients attempt suicide. So this is something that we're seeing very regularly. When I first started this work, this number of hours in terms of training was 1 hour. So it has come up to 4 hours, so that is good. Psychologists and psychiatrists over the last several years, more training around suicide prevention and intervention has been integrated as part of the curriculum. For other professions, this still is something that is lacking in many of the graduate programs that clinicians are attending. And so this is something that I've been on the bandwagon about, of really increasing access to training and making this a required part of the curriculum. So what I wanted to talk about, I talked about some of this on part 1, some of these first bullets, but what I want to talk about today, and what really is driving this second part of the presentation, is the clients that are what we call in the literature part of a revolving door phenomenon. This was first coined, this term revolving door phenomenon was coined in the 80s. And as we'd moved away from long-term institutionalization, which was, of course, a positive in terms of mental health treatment, what we started seeing was individuals who would go into the hospital and get discharged quickly, go into the hospital, get discharged quickly. And so this became known as the revolving door phenomenon in mental health treatment. There's been different definitions of this phenomenon. A general definition or a general consensus is that it's more 3 or more hospitalizations over an 18-month period. And what research has shown is that it's about 10% of clients that are meeting this criteria, and they account for 30% of mental health resources. So these are frequent consumers. And not only is this expensive, which is what we hear oftentimes from insurance companies, but it's also takes a toll on the client, takes a toll on the family, and it's not necessarily the most effective in terms of preventing or addressing long-term suicidality. It might get people through the crisis. I talk about hospitalization as the ultimate safety container. I make sure that clients know, I talk about it on the front end, that if you have to go to the hospital at some point, my hope is you won't. My goal is to be able to treat you as much as possible in the setting that we're in. But ultimately, if you can't be safe in that setting, or if your safety is compromised, that's when I'd recommend a higher level of care. And that's exactly what it is. It's a time to create some safety for the crisis to pass, for you to get some sleep, for you to get your medications regulated. So then you can come back and do the work, the real work around suicidality. So that's what we'll be talking about today. The other thing, again, no scare tactics, but this one's an important one, and something that my younger self did not realize when I used to think that treatment for suicidality really was done at these short inpatient hospitalization stays. What we know is that suicide rates increase exponentially after discharge from the hospital. Now, don't hear me wrong. That doesn't mean that hospitalization is not working. It does create safety, but because some of the things that we'll talk about today, it does not eradicate suicidality. Often clients leave and think, oh my gosh, I'm no better. And so that hopelessness can kind of take over and pull them down, pull them under, to think, well, it must not have worked on me. So that's one of the things that could happen. So what we know is that research has shown that individuals who were hospitalized for a suicide attempt, that their risk for suicide increases by 200% in the first 3 months after hospitalization. This is a little bit lower for those individuals who are inpatient hospitalized for other reasons, maybe psychosis or medication management. It's about 100 times the global rate for those individuals, so still high. This increased rate as compared to the global rate of suicide continues for years to come. So even after 15 to 20 years, these individuals have a 50 times greater risk for suicide than the general population. So this is something to keep in mind. Once you've had a client who's hospitalized for a suicide attempt, that they are at significantly increased risk for suicide. So based on this and some of the other things we'll talk about in a moment, there's been some discussion recently in the last 10 years as to whether there should be a diagnosis specific to suicide. Currently, suicidality is not a disorder. It is a symptom of other disorders. So we see this often in depression, bipolar disorder. We also see suicide, high suicide rates associated with other disorders. And so things like panic disorder, eating disorders, schizophrenia. And so when we see suicide through the lens of other disorders, one of the concerns is that it gets blurred in terms of treatment, because one of the ideas is that maybe if you treat the depression or you treat the panic disorder, the suicidality will subside. And what we've learned over the last several years, or 15 to 20 years, is that that's not the case, that you can't indirectly treat suicide. It needs to be, or suicidality, it needs to be treated directly. And so that's one of the factors that is driving us to look at possible diagnoses. So currently, suicide behavior disorder is under in the section of the DSM-5, that section in the back of disorders under further review. And so this is something that they're gathering more research or conducting more research on and gathering data on. Basically, a suicide behavior disorder is a simple definition of a suicide attempt within the past 24 months. And so by isolating this as a disorder, the idea is then that treatments would be developed, treatments would be specific to the suicidal behavior. In addition to these disorders, there's been some discussion of a couple of different options. And so there's been some research in the past few years related to something called acute suicidal affective disturbance. And with this diagnosis, you'll see some commonalities between these two lower bulleted diagnoses. This one includes suicidal intent, social isolation or alienation, hopelessness, and agitation. We know that agitation is one of the most imminent predictors of suicide risk. And so this would be something that might help us identify individuals who are at risk and identify interventions for treatment. We also have another potential diagnosis of suicidal crisis syndrome. You'll see some similarities to acute suicidal affective disturbance. The feelings of entrapment or being trapped is a common symptom of suicidality, chronic hopelessness, affective disturbance, loss of cognitive control. So as an example would just be ruminations, wanting to die, hyperarousal or agitation, social withdrawal. So these are some things that are being investigated. As of now, this is not a specific disorder. And so, as we know, this can be somewhat tricky when we look at treatment planning. Oftentimes we use diagnoses to guide us. And so that's one of the reasons suicidality can kind of get lost in the shuffle. I can get on my soapbox about using diagnoses to dictate treatment in the first place. I'll talk about that in a little while, but that is the world that we live in right now. All right, so let's talk about some foundational components in treating individuals with suicidality. I'm going to talk about the therapeutic relationship, understanding the suicidal mind. I did talk about that in part 1 of the presentation, but it's such an important aspect of really working closely with suicidal clients that I want to include it here. We'll talk about how to talk about suicide with your client, measuring progress. I will talk about safety planning, because if you did miss the first presentation, I think it's an important component to address. I won't go into as much detail as I did the first time, but I do want to make sure that I don't gloss over that, because it's an integral part of working with chronically suicidal clients. And then I'll talk about a suicide timeline. So the therapeutic relationship is probably the most, I'm debating on that, the therapeutic relationship versus some other aspects of suicide intervention. But I feel confident in saying that it's the most important aspect of working with suicidal clients. In fact, it's the most important aspect of working with any client. And what we know is that the therapeutic relationship accounts for why clients improve as much as any treatment intervention. I love this quote that Norcross and Lambert had from their paper on the therapeutic relationship as an evidence-based treatment method, which was efforts to promulgate evidence-based practice without including the relationship are incomplete and potentially misleading. What research shows when they've done studies of isolating the factors that contribute to good outcomes, the therapeutic relationship accounts for the most variance in predicting good outcomes. So we need to understand that as part of working with clients who are suicidal. And in fact, one of the most touted interventions for suicidality, the CAMS approach, rests on the therapeutic relationship. So we'll talk a little bit about that. The other important aspect of the therapeutic relationship that I think that we don't talk enough about is hope. And hope has been looked at really even as the foundation of the therapeutic relationship. There is a term called hope bonding, and I really like that. I get an image of sitting across from a client or beside a client even, and the strands of connection between us are built on hope. And the first thing that a client attaches to in meeting with you is hope. And so their hope for something different, their hope for being understood, their hope for a different life. And so I don't want us to underestimate the value of hope and how we may communicate our hope for a client. So things that sometimes don't even seem like they make a difference. I had a story that always has stuck with me. That's really a story of hope. I wish it was mine. It wasn't. I think that it was. You all may have read it because it was in a introductory therapy handbook. So was it Corey? You guys can think back to your graduate school days, but Gerald Corey is who I think it was, but he was a psychologist, and he talked about his first work was in a prison, and that in this work, he did mostly assessments. And one day, an inmate was being paroled, and he came by and said, "Hey, doc, I want to thank you. You changed my life. I now see possibilities. I have a job set up. I've reunited with my children. I have a lower conflict relationship with their mom." And Dr. Corey was like, "Oh my gosh," he said, "Well, you're welcome. You did the work, well, whatever you say, all the things." But he was like, "What?" He had to look through his notes because he didn't even remember this guy. And so when he was looking through his notes, he saw that he just did intelligence testing with him. And so he said, "I'm looking through what you've described is the work of years of psychotherapy. And we had one session." And he said, "So what was so powerful?" And he said, "You told me that I had an average IQ, and I always thought I was stupid." Oh, that gets me. And so I think about like how powerful those things can be when we don't even realize, the hope that even something like assessments can provide. We'll talk about assessments in a little while. So thinking about that of when you're meeting with someone, not to be a Pollyanna, because that's not going to be received well or in an authentic way, and may dismiss some of their pain, but being able to connect in a way that acknowledges and validates their pain and provides hope for a different life. So one of the first ways that we do that actually is through understanding the suicidal mind. I'm going to share with you today a variety of interventions that you can use with clients. And I'm one of those people that loves a good toolkit. And so I like to share those. With that being said, this slide is probably the most powerful intervention that you will do with clients. And it's if we can meet them where they are and truly understanding what it means to be suicidal, even if you've never experienced it, that is the first step and provides the foundation for the rest of the work. So suicide, making a decision to kill yourself, is a decision, and it's made by someone who is seeking relief from psychological pain. There's a term for this psychological pain. Ed Schneidman, who was the first suicidologist, the term suicidologist is someone who is an expert in the field of suicide. And so he started the American Association of Suicidology, and he coined the term psychache. I love this term because it provides words for an experience that's indescribable. And so often when a client is describing what's behind their desire to die, I will say, oh, there's a word for that. It's called psychache. It is the psychological pain that is so intense and so painful that you'd rather endure the pain of dying than to continue with the pain of living. And that concept in and of itself may provide some understanding to the person in front of you or beside you. I'll talk about this in a moment, but one of Thomas Joyner's theory of suicide, the interpersonal psychological theory of suicide, states that 3 factors converge to place a person at risk for suicide: that they feel burdensome, they have no authentic connections, and they have a sense of fearlessness around death. So some of the interventions that we'll discuss today will home in on these factors. The other important aspect of understanding the suicidal mind, and one of the first things that I explain to clients, is this idea of constricted thinking. So constricted thinking is actually an adaptive phenomenon that goes awry in this situation. So in a fight or flight response, our vision, our attention zooms in to whatever it is in front of us. So I always say, like, if a bear came in my door right now, all of my attention would go to the bear. Everything else would fade to the periphery. That is adaptive. That is, that allows me to do what I need to do to, fight off the bear, whatever you're supposed to do with the bear. So in suicidality, though, this same phenomenon takes place. So everything fades to the periphery except for suicide as a solution. And so by definition of being suicidal, you can't see any other option except to kill yourself, even when these other options are available, because your attention is just focused in on this one option. So I talk to clients about, I use an analogy sometimes of a burning building. I don't know why I think of like a movie theater, but that when you're suicidal, you're in a burning building, you're in a movie theater that's on fire, and you feel like that your only way to escape is to get to the roof and jump off, because that's the only avenue that is available to you. And instead, there are maps of the building to get out. I can see that map. Maybe your loved ones can see that map, but you can't. You only see this one route. And so, because of the smoke of your ruminative thoughts and the fog and the panic that has wiped out other possibilities. So during these times, and this is why the therapeutic relationship is so important, it is imperative to rely on others who can see the full map. And so even telling yourself, I've had clients develop this as a mantra of the worst time to kill myself is when I'm suicidal, because, and that sounds kind of silly, but you're not seeing things in a full picture. You're seeing just a snapshot. You're seeing just one route, which is adaptive in many situations, but not in this one. And then finally, I think a conceptualization of suicide that can be very harmful to our clients is the conceptualization that suicide attempts are attention seeking. And often I've heard clinicians say this, I've heard families say this, and I think it comes from our own fears, our own fatigue. And so this is understandable that in working with these clients that we have our own countertransference that we need to work through. But by labeling suicide attempts as attention seeking, we often then ignore them. Because what are you supposed to do when someone is trying to do something for attention, right? You don't give them the attention. And that is the exact wrong thing to do. So I talk about with new clinicians, especially, to reconceptualize it as help seeking. If that's where your head is going and thinking, this is more that this individual sees no other way out. And so this becomes their solution. Think about them in the burning building. And so we have to help provide this other solution and help them slow down during that time to not act on that solution. One of the things that is helpful in understanding the suicidal mind is a conceptualization of suicide that is a theory that I subscribe to, which is Thomas Joiner's theory, which says 3 factors converge to place a person at risk for a serious suicide attempt or a death by suicide. And the first is burdensomeness. So this is something that you want to have your radar up on in assessing your client. Are they speaking to feelings of burdensomeness? Often this happens in the classic way where they say, my family would be better off without me, or my life isn't worth anything. I don't make a difference. I also see this play out, though, in different ways. The burden of carrying psychache, as an example, is another way burdensomeness shows up. And then finally, the way I see burdensomeness show up is through the burden of treatment itself. I see this a lot of times with clients with PTSD who feel like there is no life on the other side of their trauma, and that this will continue to haunt them. This will continue to knock their knees out from under them for the rest of their lives. And that the treatment of even thinking about addressing your trauma feels overwhelming and insurmountable. And so they feel stuck. And so that burden could be the way that this shows up. The second factor is thwarted belongingness. This is the term that Joiner uses. I tend to say feeling disconnected, feeling unknown, feeling misunderstood. This is something that is a factor that plays a role in this. So interventions, again, when we get to that part, will address this. And the third factor, which is the tipping point, is what's called acquired capacity for lethality. And this is a combination of a fearlessness around death and acquired pain tolerance. So that's what this picture is here. In the research that we've done, we look at pain tolerance through, this is an algometer that measures pain pressure on your arm. Sometimes we've done it on the, I don't know what this part of your anatomy is called, but this part of your, between your pointer finger and your thumb. And it measures the person's tolerance to pain. And what we know is that individuals who are likely to die by suicide are individuals who've acquired a capacity for lethality, or for pain and lack of fear related to that. So these come together to place a person at risk for suicide. So this is what it looks like in action. So we've got the burdensomeness and thwarted belongingness on one side, and then the capability of suicide on the other. It's this crossover where individuals are at risk for a serious suicide attempt or death by suicide. And so you may ask yourself, how do people acquire capacity for lethality? Well, in a variety of ways. One is through suicide attempts. So this is the previous suicide attempts is the #1 predictor of the death by suicide. And so individuals who've had multiple suicide attempts, especially those that increase in lethality, are acquiring a tolerance around pain. They are desensitizing themselves around death, so that that final act is not as difficult. We are not wired to kill ourselves. We are wired to protect ourselves. It's part of our evolutionary makeup. We're wired to survive. So to go against that requires tremendous, the word courage is misunderstood in this context, because it is often glamorized. I don't mean it in that way. What I mean is here, courage is facing a fear of killing yourself. And so individuals in this way are willing to face that fear. And so how do they get there is the important question. And it's through little tastes of violence toward themselves, through a suicide attempt, through self-harm, through substance abuse, through eating disorder behaviors, even passive violence, where you're the recipient of violence through trauma or abuse, tends to up the ante here a little bit in terms of this acquired capacity for lethality. I think about it as a big bucket, and events in your life go in that bucket that up your acquired capacity for lethality. You can't take things out of that bucket. But what you can do is put the lid on so that you're not adding more to the bucket. You can also create some buffers in your life so that in terms of safety planning, means reduction, means restriction, that can address this aspect. But those are the main interventions around this, because it is something that is, once you have it, you can't get rid of it, kind of thing. Here is where we're going to get the most bang for our buck in terms of interventions, is through this desire for suicide side of the equation. All right, so let's talk about talking about suicide. I mentioned this already in terms of setting the stage. So in working with clients who are suicidal, it's important to set the stage early on around safety, around when you would, this is part of informed consent anyway, but when you would recommend hospitalization or when an involuntary hospitalization might be necessary. It's important to talk about this, to say, hey, you can talk about wanting to die. In fact, that's going to be an important aspect of the work that we do. I am not going to overreact to that. I'm not going to, call the ambulance because you've said you wanted to die. I'm not going to do that. The times that I would call the ambulance would be when you say, I want to kill myself, I have a plan, I'm going to carry it out, and I can't create safety around that. And if those are the times when we can't create safety, those are the times when we need to get you to a place where safety could be created. And that is what the purpose of hospitalization would be. In working with clients who are suicidal and their families, it's important to use appropriate language. So we don't say, this makes me laugh. My kids are grown, but they always had a list, and then they like to say it like, we don't say stupid. We don't say, so this is what it sounds. So we don't say commit suicide. The reason for that is that it's a pejorative term, and it actually takes away from the death itself and treats it as like a crime, versus really recognizing the death itself. So we say die by suicide or kill yourself, rather than commit suicide. So it takes a while to get used to that change in language. But it's an important aspect of working with these clients. And especially if you're training others, you want to make sure you're using appropriate language. You also want to provide empathy. This is tough for new clinicians because often they feel like if they provide empathy, it somehow validates the person's desire to die or their reason for dying. So one of the most powerful things that we could say is, I can understand why you might want to kill yourself. I'm putting myself in your shoes as much as I can. And when you're saying, I see no way out, I feel like everyone hates me, I've lost 3 jobs in the last year, and it just feels peaceful, that if I could just be on the other side of that. I can imagine feeling that way. And of course, that comes up as an option for you. That is an empathic response. You have not put something in this person's head that they haven't already thought about. You haven't encouraged them to kill themselves. Instead, by validating their experience, it actually might take a little bit of the energy out of it, because they don't necessarily have to make you, they don't have to spend their energy trying to make you understand why they should die. You have reflected back that you can understand from their perspective. And sometimes I'll use some disclaimers in there of things like, I can see things in a different way. It's easy for me to say because I have not gone through all of these things that you've gone through in the past year. So you can add some things like that if it makes you a little bit nervous to land on the being in their shoes. I will add here that one of, you guys know, you do this work. It's hard. And so it is, working with clients in pain is tough on us. And when you work with clients who are suicidal, if you have a caseload of clients, a high caseload of clients who are suicidal, this can take a toll, because what we know as part of being empathic, it is putting ourselves in someone's shoes. So I always think of that Brene Brown little video. It's like with a bear and a goat or something, and it's about empathy, and it's about how if when you're empathic, you are, instead of like looking down on the person who's down in the cellar, and saying like, gosh, it must be really bad down there, I feel really sorry for you. You have to climb down into the cellar beside them. And I think about this of the work that we do, 7, 8 clients a day, you're climbing down into that cellar and you have to access your own pain to provide empathy 7 or 8 times a day. That is really tough. And so taking care of ourselves through this is an important aspect of the work. And so having those kinds of burnout buffers are important. Having colleagues you can talk to is really important. We do want to avoid romanticizing. I'll talk a little bit about this when we get to the suicide timeline. So we need to ask, in really understanding the client's sequence of suicide attempts, we need to ask about the specifics around the event in terms of whether it's increasing in lethality. Sometimes you can start to see clients glaze over a bit, sort of like when they're talking about drugs or alcohol, where they almost dissociate a little bit and romanticize the idea of dying by suicide. So when you start to see some of that, the same way that you might with a client that is romanticizing drug or alcohol use, bringing them back to the present through mindfulness, present awareness, and just even in terms of the language that you use, refraining from sort of a Romeo and Juliet. This goes without saying, but I'm saying it anyway. But of like the tragic death, and where everyone, even when you're providing empathy for them, and everyone would be so sorry after you died. You really want to refrain from some of that, because that can be something that escalates some of their actions around suicidality. You also want to avoid shock and reactivity. So you don't want to be a robot, but I've had newer clinicians, and internally, we've all probably had some of our shock around some of the things, but I've had newer clinicians even say, like, as a part of trying to be empathic, say things like, oh my gosh, you did what? And you still lived? How did you live after that? Did they say that you should have died? We don't want to react with that kind of reaction. And part of that is because we want to make sure that the client in front of us, beside us, knows that we can hold this. We can hold whatever it is that they're going to tell us. And so we want to make sure that that's communicated. So one thing that's important as part of the treatment process is measuring progress. So I shared with you earlier that little snippet of the psychologist who had provided intelligence testing for the inmate. Measuring progress in terms of suicidality is really important, because remember, part of it is that constricted thinking. It's hard to see things outside of that. So often these clients don't feel like anything is better. I'll talk about the CAMS approach in a few minutes, but I love the video. If you all haven't taken, I have no stock in the CAMS. I don't get any kickbacks or anything. But if you all haven't if you're interested in working closely with suicidal clients, if you haven't taken that course, it's a 3-hour course. And it's excellent. It's David Jobs and a client. And at one point in the session, like session 6 or so, the client comes in and is angry and I'm not making any progress. This isn't working. You said it would work. And it was helpful in the session for him to be able to show, hey, look at the progress. We've got the progress here. I wonder what's happening that's making it feel like there isn't any progress, and what's coming up. And so it actually was a very heated session. Those of you who've watched it may be familiar with it, because he got some flack for it, because Jobs responded with a lot of energy himself. But it seemed like it was what was needed for that client, which was very much related to the therapeutic relationship and how strong it was. These are some of the questionnaires that I like. The DSI is a good one because it's 4 questions. And so a score of 3 or above indicates risk for suicide, but it also can show progress. And one of the 4 questions is, I'm not having thoughts of killing myself. And then it is rated in different gradations of those thoughts. And so that's something that's quick and easy and can be used from session to session. Another questionnaire that we use is the interpersonal needs questionnaire. This is developed by Joyner and his team out of Florida State. And it really focuses in on those 2 factors, burdensomeness and thwarted belongingness, that play such a role in suicide desire. And so it can give us a good picture of intervention, if our interventions are working in those 2 lanes. And then finally, the suicide status form, which is used as part of the CAMS approach, gives a week-by-week check-in around some of the suicide drivers that we'll talk about in a little bit. All right, so I'm going to go over the suicide timeline, and then I think that then we might have a break. I think this is the last one before we jump into the other interventions. So this is a handout in your packet where you'll have the QR code at the end of the session. I now use this. I don't use the form. I have this kind of just in my head, and I jot it down. You'll see this on the next piece of paper of what this looks like in action. But what you're looking for here are reasons for living, for dying, risk factors, protective factors, and then along a timeline, you're going to track and document when their suicidal thoughts started, when their hospitalizations were, when some of their other symptoms started. This one that I have here is for a client that has substance use disorder. And so we want to look in self-harm. So we want to look at the purpose of the symptoms, or the function is another term I often use, of the symptoms. So what makes you self-harm? That people might look at you kind of crazy when you say that, right? Of like, well, what do you mean? What makes me do it? Or what makes you use alcohol? We want to get at what's driving it. So it could be that it releases pain, it releases tension, it relaxes me, it lubricates my social interactions. So we want to get at the purpose of that. You'll notice here, we also have the function of suicidal thinking. So one of the reasons that it's so important for us to dig into this is that suicidal thinking often serves a purpose. It is the same way if you think about self-harm, where we talk about sometimes self-harm takes the edge off for individuals who are suicidal. It's like, if I could just hurt myself, then maybe I won't kill myself. And there's some truth in that for clients. And at the same time, what we know is that over time, self-harm, we're adding things into that bucket, right? That acquired capacity bucket. So in the short run, maybe it is keeping you from killing yourself. In the long run, it's increasing your risk for suicide. I'm not giving a lecture to clients around this. I'm telling you all this. But suicidal thinking serves that same function. Sometimes this is that fantasizing, romanticizing. If I can just think about how I'm going to kill myself, that might decrease me acting on it. And so sometimes there's an attachment to these thoughts that, on one hand, clients will say, I'm tormented by these thoughts and I don't want them there. And in another way, they're afraid to let go of them, or afraid to not hold them as tightly. So this is an example of what one looks like in action. You don't have to read I'm going to tell you what these things say. So this says suicide trajectory or timeline, and this was the client's name. And so you'll see along the timeline here that, move faces for a second, that she was now 22 years old. And in fifth grade is where we'd started here. So we tracked her different suicide attempts. And so here, this is her now. She remembered that she was first diagnosed with depression and wanting to die when she was 15 years old. She started her eating disorder. She was diagnosed with her eating disorder when she was 19. Her first treatment for her eating disorders when she was 20. So we also then have diagnosed with her eating disorder. So we have her reasons for living, reasons for dying. Here, the purpose of her self-harm and what that looks like. And then we have her 2 suicide attempts. So this is what I wanted to dig into a little bit, was that her first suicide attempt was when she was 16. And in that one, she overdosed on aspirin. She took 30 or 40 pills. And in the most recent attempt, she had OD'd on approximately 70 pills. It was a mix. She was hospitalized for 2 nights in ICU and then 5 days in psych. So this was a much more severe suicide attempt. And one of the things that I pointed out to this client, this was a young client, 22 years old. She came into us after this suicide attempt, after her hospitalization. One of the things that I did point out to her was this idea of increasing capacity for lethality, and how this attempt was much more severe, and what were some of the things that happened between here that even could have contributed to the lethality. So she'd started her eating disorders, which included laxatives and restriction. She was purging. She was self-harming. And so it makes sense that this increased in lethality. And she reported that she was fully intent on dying at that time, and was disappointed when she woke up. So what we were looking at now is, and we'll get into this as she'll be someone that I talk about in some of the interventions that we discuss, is after she'd come to us after this suicide attempt, and she'd had the 5 nights of psych, she was in a state where I'm not going to act on it right now because I don't think I know what happens. I don't think that I can do it. If I knew I could really die, I would do it, but I'm afraid I'm just going to end up back in the hospital. So if I had a surefire lethal way that I thought would work, I'd do it. And that's where she was when she came to us. So this provides a good picture and a good peek into the client's history. And we gather that through a biopsychosocial, but this digs in a little bit more specific to suicide. Okay, I do want to talk about safety planning, but I am going to take a quick 5-minute break, and then we'll come back at 10 after the hour, and we'll dig in the rest of the time to the interventions. All right. So we'll pick back up. I do want to quickly go over safety planning, just to make sure that this is an integrated aspect of the work that you do. I won't focus on this for as much as I do in the first part of the session, or the first part of the presentation, but safety planning is an integral aspect of making sure that there's enough safety in place to do the work for chronic suicidality. And so we need to have a safety plan that includes what the client will do if suicidality increases when they're outside of session or away from the facility, depending on what level of care that you work in. We use a de-escalation and safety plan. So this is used for all clients, regardless of suicide risk, because the thought is that if suicide risk increases, that then they'll have a plan in their back pocket to use if they're away from session when that happens. What's also included in this is means reduction, how to make the environment safe at home or in any other setting that the client is in. This is a very important aspect of working with clients who are moderate or elevated risk. And then my favorite aspect of this plan is the last line, which is the reason that's the most important to me and the reason that I want to keep living. And we put that there, the client puts it there, so that it can help them during that time of constricted thinking, remember things outside of their funnel. Excuse me. So I have in here, an example so that you have this. I also had that in the first presentation, but you can have that as an example. And then a blank copy is included in your handouts. One of the assignments that I sometimes give clients is to start tracking their reasons for living. And at first, they may have very few, but over time, they may add things to the list. Excuse me. So for instance, this client, I want to see my son grow up, was his number one reason for living. And it's important for these reasons for living that you don't become the mouthpiece for the reasons the client should live, because then it becomes you convincing them, just like everyone else in their lives, of why their life is valuable, why they should live. This has to come from inside, and their reasons for living may have nothing to do with whatever you may think a reason for living should be. So these are the an example of an assignment that I'd given a client, and he came back in with his 8 reasons for living, and then he was going to continue adding to the list. All right, so let's talk about treating chronic suicidality. I'm going to start with evidence-based interventions for suicidality. I'm going to talk a little bit about process-based therapy, and then identifying suicidal drivers. So several evidence-based interventions for suicidality have been identified. So one I've already talked about, which is the CAMS approach, the Collaborative Assessment and Management of Suicidality. Another is cognitive behavior therapy for suicide prevention. And this also has a version with teens, and then DBT. originally DBT was Marshall Linehan actually really wanted to develop protocols for individuals who were suicidal. But at that time, to get grant funding, you had to have a diagnosis that matched the whatever it was that you wanted to study. So that's why she chose borderline personality disorder, because that was a disorder with high rates of suicidal behavior. But she was actually interested in suicidality in general. And so dialectical behavior therapy was created with that in mind. More recently, what we've been seeing in the past 5, 6, 7 years is a shift away from diagnostic specific evidence-based interventions. Those of you who are working closely with clients understand that the applicability of these interventions is limited. And so what we tend to do is an amalgamation of different evidence-based interventions. And to date, there really hasn't been a rhyme or reason for how to integrate those well. Chris Fairburn developed several years ago a transdiagnostic approach to eating disorders that was along these lines. David Barlow and his colleagues developed the unified protocol for emotion affective disorders. So we started moving in that way. But most recently, Stephen Hayes of Acceptance and Commitment Therapy and Stefan Hoffman of sort of a CBT guru came together to say, we've got to stop the madness with all of these evidence-based interventions. Let's, instead of learning, we could spend our entire careers learning trying to learn each evidence-based intervention, and we die before we learned all of them. So what Hayes and Hoffman did is they said, why don't we integrate the effective ingredients from all evidence-based interventions and train therapists on those effective ingredients. Secondly, instead of looking at diagnoses, because there's so much overlap in symptoms across diagnoses, I can do another talk on how the DSM has failed us and how using diagnoses to guide treatment is a misstep from my perspective. So what PBT does is it looks at the drivers behind the symptoms, and those drivers may be similar across symptoms, across diagnoses. So those are the two aspects of PBT. PBT is somewhat of a misnomer in many ways. Hayes and Hoffman didn't check with me when they came up with the title of it, but I would have given them feedback that process-based therapy is confusing, because it's not a therapy. First of all, it's a framework, and we're not processing anything. What we're talking about here in terms of process is a driver behind the disorder. So we'll talk about drivers in a moment. What I like to say instead is an integrated framework. So let's just think about it in that way. And this integrated framework is something that works very nicely in working with clients who are suicidal. So here is an example of what we train our clinicians on. We didn't come up with these. We call these intervention bubbles. Hayes and Hoffman refer to them as treatment kernels. These are the 12 interventions that are common across all evidence-based modalities. We've simplified some of these terms to encompass more, but working with emotions is emotion dysregulation or emotion regulation techniques. Working with behavior management. Working with thoughts might be cognitive diffusion, kinds of things. So, or if you're CBT, cognitive restructuring. So our clinicians are trained in each of these bubbles and then trained on how to apply or which trained on how to select which intervention to apply for which client in which situation. We have bucketed different core processes or drivers behind disorders into difficulties with emotions, difficulties with behaviors, difficulties with thoughts, difficulties with relationships. And the goal is to apply these interventions to help clients pivot from those maladaptive processes into adaptive processes. So difficulties with emotions becomes emotion flexibility and acceptance. Difficulties with behaviors becomes valued-centered living. Difficulties with thoughts is mindful self-compassion. Difficulties with relationships becomes interpersonal connection. So the art of therapy in process-based therapy or an integrated framework is knowing when to lean on which intervention for which client and how to select those. And so that's part of the training as well. When we apply this to suicidality, it blends quite nicely. So David Jobs and his colleagues have looked at drivers as part of the CAMS approach. We look at drivers of suicidality. What is making me want to kill myself? What is driving that? And the research they've done has bucketed those drivers into four main categories. And these include unpleasant internal states, which corresponds nicely to our bucket of difficulties with emotions. Another suicidal driver is self-hate or difficulties with self. And so that corresponds to difficulties with thoughts in our integrated framework. Role responsibility corresponds to difficulties with behaviors, and relationships obviously corresponds to difficulties with relationships. And so identifying interventions that may be specific to each of these for suicidal clients it can be helpful in working with them through their chronic suicidality. So in your handouts, you have a worksheet from CAMS that helps identify drivers of suicidality. And so you can use this with clients. I recommend completing the training first, which is relatively inexpensive to complete this worksheet. So once you've completed the worksheet and you understand that client's drivers, you can apply interventions accordingly. I'm going to go through some interventions based on each bucketed driver. So we're going to start with unpleasant internal states. So there are a variety of techniques that you can use with emotion dysregulation or unpleasant internal states. I'm going to just share a couple of techniques here that you could use with clients. The first is emotion acceptance. And so helping clients understand the futility of experiential avoidance or the futility of ignoring their pain or trying to push their pain away. I love this worksheet that looks at, this is moving away from your values or the life that you want, and this is moving toward your values or the life that you want. And you just go through each of these little bubbles. So what matters most to you in your life? You'll list things here. So if it was the client that I shared earlier, he would say, being there for my son. What are things that takes you toward that? Well, when I have him on Wednesday nights and on the weekends. And so when we go to baseball games together, or when he texts me when he gets home from school and I respond, what are some of the thoughts and emotions that you have? He would have said, you know, I've thought that I'm a good dad and I feel fulfilled and I feel proud of myself. And then which thought or emotion has the power to stop you in your tracks or hook you away from your values? And as an example with the guy that had his reasons for living. One of his was when he felt like he was a bad dad. Remember, that was his number one reason, was to be there for his son. So if he had a thought, I'm not showing up. So things that sometimes happened for this dad or this client was that his son would text him and he would feel so depressed that he didn't respond to him. And so then he'd say, I'm a bad dad. It doesn't matter. It might even be better for my son if I'm not around, because it's worse that I'm here and acting like I'm dead. I might as well be dead. And then what this client would do in this situation, this is the example of experiential avoidance, is that he would then kind of get in bed and cover up his head, kind of thing. And that would actually, in the moment, provide a reprieve. So it would provide relief because he's avoiding everything. But in the long run for him, it was taking him more away from his values and more away from the person he wanted to be with his son. So this cycle is what our clients get into all of the time, of avoiding pain in the short run feels good, provides relief, but in the long run, it creates suffering. Some of the techniques that I like to use with clients around emotion acceptance, this is from acceptance and commitment therapy with Hayes, is a caring exercise, which is included in your handouts. But picturing a difficult time, it could be for our clients, suicidality, wanting to die, wanting to kill themselves, and then envisioning this in a way that creates a caring image for the client. I like the one of holding it in my hand. And so when you're holding that pain in your hand in a tender way, a delicate way, a loving way, an honorable way, it's a very different experience than what often happens with our emotional pain, where we push it down, beat ourselves up for it, which is another avoidance strategy in many ways. So this is something as an introduction into acceptance. Another intervention that I really like to use for emotion acceptance is it relates to arousal reduction. So many of you may be familiar with polyvagal theory. This is something that we integrate with our clients. The idea that our parasympathetic nervous system is separated into a dorsal vagal and ventral vagal response. And as part of that, having awareness of your vagus nerve and your arousal as related to that is an impactful aspect of emotion regulation. So we do some physiology lessons with our clients to help them understand this. And as part of that, we work on widening the window of emotional arousal or physiological tolerance, however you want to talk about it. There's different ways. I like the way that Deb Dana talks about it. She has a ladder that she uses. I tend to use this image of the window of tolerance in that I look at the optimal window of tolerance is in the middle. And then there's hyperarousal and hypoarousal. And often our clients, when they come in, they have a very limited and narrow window of tolerance, and they have a lot of dysregulation between hyper and hypoarousal. So one of the things I'll talk about is helping our clients map their window of tolerance is an important aspect of this, and then starting to widen that window. One of my favorite books for this, I have it right here, in fact, is polyvagal exercises for safety and connection. And so this is the basic framework that Deb Dana uses as it relates to polyvagal theory. And she uses an acronym of BASIC. And the B is for befriend, the A, attend, S, shape, I, integrate, C, connect. And each of these in the book has a variety of activities to promote the acquisition of skills in each of those areas. My favorite one is befriend your autonomic nervous system. And so many of our, this also has a compassionate view. Many of our clients have a more of a hate relationship with their nervous system. They're mad at it. Why does it keep doing this? Why am I having this heightened startle response? Why am I having these panic attacks? Why do I feel this way? Stop. So the first aspect in getting to know your nervous system is befriending it. So mapping it. So what are your, this is on the window of tolerance that I just showed you. We could look at what are the triggers for sympathetic response for this client versus a hypoarousal, a dorsal vagal response where you dissociate, you feel numb. I love Deb Dana's term of glimmers. We talk a lot about triggers in our field, but glimmers are little indicators throughout the day of regulation and of a ventral vagal response, which is regulation, connection. And so that's, here in the heart versus here in the gut. Dorsal's more here in the gut. So what are some glimmers of that? So starting to map that out for a client of what does that look like for you, of how do you know you're in ventral vagal? Maybe it's when you're petting your dog. That's pets provide a good ventral vagal response. Then we have attend. One way to attend to your nervous system, the A in basic, is to start to track during the day where you are in terms of your arousal, noticing triggers, noticing glimmers. It helps clients, these terms come from Peter Levine from somatic experiencing, but starting to develop a language for some of the arousal sensations. And so I give clients this list so they can start to use those. And so once you've befriended and attended, you can start shaping your nervous system. So you're starting to widen that window of tolerance. And so you can shape your story through sound, through movement, through breath, through the environment. These are ways that as you're getting to know what activates you, what provides glimmers, you can start to shape that experience. Then you can start to integrate what Deb Dana refers to new autonomic rhythms. An example of this is exercising the vagal brake. So recognizing that our sympathetic nervous system from our brain to our heart is, it carries those messages of fear and fight or flight. The vagus nerve, which is more of a parasympathetic response, can also be activated. And we can learn ways to activate that can offset the sympathetic response. So that's the best way to do it is through breathing. And that is one that that's always handy dandy nearby that you can lean on. And then connect. We'll talk more about this in the relationship section, but connecting to others and having a plan for that is one of the best ways to create that ventral vagal response, widen that window of tolerance. And it's not necessarily just to others. It can be something outside of ourselves in terms of gratitude, in terms of awe, putting ourselves in experiences that cultivate awe. or having a gratitude practice is something that can be part of that resilience plan to create a resilient nervous system. The second bucket that I'll share some techniques on is around self-hate. This is something that we often see as a driver behind suicidality, that there's something wrong with me. I'm defective. I don't deserve to live. Breath is wasted on me. These are the things that we'll hear. And so how do we start to create compassion? And you'll notice that we're not talking about self-love, even though compassion is a form of love. Where compassion and cultivating compassion is a broader concept than love. So I'll explain that in a moment. So how do we start to cultivate the compassion itself? I'll talk about some ways to do that. This is where we lean on some compassion-focused kinds of therapies. The more recent applications of acceptance and commitment therapy integrate a lot of compassion exercises. So when we talk about compassionate self or compassionate thinking, I talk with clients first about the concept of compassion, because it's a threatening term to a lot of our clients. They think if they start feeling compassion toward themselves, it's like self-pity, or that they're going to let themselves off the hook. And so we need to create some definitions around what compassionate thinking is. And in many ways, it's the opposite of fear. So it's opposite of threat-based thinking. So here, when we look at threat-based thinking, again, in that constricted thinking, compassion-based thinking may be the opposite of constricted thinking. So threat-based, you're homed in on the threat, judging, labeling, critical, ruminative, and compassionate thinking is broader. It's more focused on understanding. It is associated with more emotional flexibility and psychological flexibility. It is associated with feelings of peace and comfort, associated with kindness and empathy. So I often provide some psychoeducation around this for clients. And that this is why we're starting to exercise and build this muscle. We are not trying to get rid of threat-based thinking. We have to have threat-based thinking to survive. It is adaptive to have threat-based thinking. But when it's the only type of thinking that you have to rely on, you're limited. So one of the first ways that we may start to build our compassionate self is through soothing breathing or affectionate breathing. I have a clip here of that, a link. This is Kristen Neff's website. I love thinking about breath as a spiritual phenomenon. It comes from the Latin root of spiro, so think like spirometer, which means soul. And so breathing is a connective act, connects us to others. It connects us to ourselves. And that, when we start thinking of it in that way, it can be a compassionate act. I have a script for this in your handouts. The other technique that I love to do, I do this in a group oftentimes, is creating a compassionate companion. I have the fairy godmother here from Cinderella. But your compassionate companion can be someone real. My compassionate companion is my grandmother. And I imagine my grandmother, when I'm having a hard time accessing compassion, I imagine my grandmother and I can access that part of her in me. And so when you're doing this imagery, you would have the same, or your client would have the same kind of image. So you really want to get down and dirty with this with your client so that the imagery can be really effective and can be vibrant. So what are the visual qualities, the sound of voice, any sensory qualities? How would this person relate to you? How would you relate to them? What might they say? And so using some of that imagery to start to cultivate that, almost like a little image on your shoulder. And this isn't one of the first things you'd want to do with clients, because remember, they may at first have some pushback around the idea of compassion. So creating this image might feel somewhat threatening. So you want to get some buy-in before you did this. And this is in your handouts as well. I'm a big fan of good old-fashioned empty chair gestalt work. But in this way, I love the compassion lens to empty chair work. So often when people do empty chair work, they do 2 chairs and you just go back and forth. So for instance, you might have on one side your self-critic, and on the other side you might have your like rational self, or something people might say. And they get in an argument back and forth and back and forth. And that argument is a representation of the internal world that our clients are in. So that isn't necessarily effective. Adding a third chair, which helps the client start to move out of that back and forth, is what's the effective ingredient in this application. So you might have the self-critic and the vulnerable self. So that's the back and forth. But then you would have the compassionate self in the third chair. And that compassionate self provides compassion to both parts. So this is the important aspect, sort of integrating some internal family systems here as well. Compassion is toward the critical part of you, that part, that self-hate part. That part is served a purpose. It's served a function. It's probably seems like it's kept you safe, and maybe it has kept you safe. It's kept you in line. And some of the narratives that our clients will say is, without that, there's no telling where I would be right now if I hadn't been so hard on myself. So I'm not getting rid of that. And if you're trying to tell me that's what's going to happen with developing compassion, no, thank you. Instead, with the compassion part, we may start with compassion toward the self-critic. How hard it's been for that part of you to carry the load, and has had quite a job. And then also compassion for the vulnerable self. So this is a distancing technique in many ways, as part of developing that in somewhat of a wise mind approach as well. That compassionate self. Compassionate letter writing. I always want to make sure when I describe this that people understand that this is not, oh, just a warm, fuzzy letter to yourself. Warm, fuzzy letters could be nice, but when we have a very active self-critic, warm, fuzzy letters actually activate that self-critic. So a compassionate letter is one that can validate your distress and can validate that inner critic or that threat system activation. It's understandable. This is an example of that your old safety strategies are kicking in. It's understandable that your self-critic is getting activated because that's how you've protected yourself. And I have a lot of compassion for that kind of thing. So compassionate letter writing is a way, when you're feeling at a time where you may not be activated, where you can write something that you can read at a time that you are activated. Then the third bucket is role responsibilities or valued-centered living. And here, this comes from an ACT focus, acceptance and commitment therapy, of identifying your values and living a life in concert with those values. I love Hayes' quote of "You hurt where you care and you care where you hurt." And that speaks to values as being such an integral part of the life that we live. There are a variety of value exercises that are out there, and you can choose from many of those. I love Brene Brown's value exercise, and we actually use this as part of our culture in our company for all of our staff, of narrowing your values to 2 main values. And she has lots of reasons that she goes into for doing that, that when you get beyond 2, it becomes difficult to kind of keep them wrangled. And so narrowing it down to 2, which is really difficult, is part of the exercise. And then you would build activities toward those values. So she has a list of the different values that that are also included in your handout that you can use. At our company, we all know each other's values. My top 2 values are love and making a difference. And so when I feel like I get off track, I remember those things are important to me to pull me back in line with the life that I want to live. So this is an ACT exercise of trying on a value. A lot of times our clients are coming from a place where they have confusion around who they are, who they want to be. And so identifying their values is tough. So trying on a value is something that is an ACT exercise of living with that as your top value for a little bit, and then changing it out if it doesn't quite work. Which I've gone through that myself, of like, I lived with that value for a little bit, that doesn't seem quite right. I think it's really this. And so that would be something that you could use with clients. And then the last bucket that I'll talk about is relationship issues. If you remember, the thwarted belongingness and burdensomeness are one of the main drivers of suicidal behavior. Belonging and connection is a core human need. In fact, we are wired for connection. Our ancestors who were connected to one another survived and passed on their genes, the idea of safety in numbers. And so when we feel like we don't belong, or we feel disconnected, unknown, unseen, this is the root of suffering. And so this aspect of creating connection, even if it's through the therapeutic relationship as a first step, is really powerful. One of the things that I like to do in relationship work is integrating schemas. So originally, schema work was done by Jeffrey Young and it was Aaron Beck initially, but you all may be familiar with schema therapy. This has been used for personality disorders and with relationship conflicts. Most recently, schema work has been integrated into ACT, again, looking at some of the effective ingredients of evidence-based interventions and pulling those together. So understanding what our negative core beliefs are, our negative schemas, can really be powerful in understanding how we perceive interactions from others. It may be through an old wound, an old relationship wound. And so knowing our schemas and those of our partner or loved one can be really healing. So the Young Schema Questionnaire is something that we use with our clients, of identifying their schemas. Many of our clients have fears of abandonment and mistrust abuse. We've talked about defectiveness and shame. The questionnaire identifies someone's top 3 schemas. And so when we start to understand the lens through which our clients see things based on old wounds, that can open up the channels for healing, to know that this is an old pattern, this is an old wound, and it's something in this new situation is triggering that. So here's some examples of how this ends up in behaviors. So if someone has a negative schema of dependence, that may show up as clinginess in relationship. If it's abandonment, then it's often blaming others. If it's defectiveness, withdraw from others. Unrelenting standards or high criticism is attacking others. So these can start to identify some of the ways that you may protect yourself in situations that may seem as though it feels safer, but it's blocking the connection in the relationship overall. So when we talk about self-hate, we can, in that other bucket, we can map out how that may impact their relationships with others and create a cycle. All right, I think we are going to be right at time. So I have a few takeaways here, and then we'll have 10 minutes for question and answers. So suicidality requires treatment beyond hospitalization and safety planning. Addressing suicidal drivers can impact chronic suicidality, and reducing suicides is possible, and we are part of that solution. I like to end with my favorite quote around hope. Hope begins in the dark, the stubborn hope that if you just show up and try to do the right thing, the dawn will come. You wait and watch and work, and you don't give up. That's Anne Lamott.
And love that one, Nicole.
I know, I love it too. Here is the QR code. So what you do, just take your phone and put it up to the QR code, and you should get a little flow code that takes you straight to the handouts.
I also wanted to note, Nicole, while you were talking, we had many inquiries come through just regarding where they could access the materials. Of course, you can access them utilizing the code here, but we'll also include it on the follow-up email that we'll send out early next week. If for some reason you don't see it, you can always email us at hello@lightfully.com, or Nicole's got her email up here as well. We do have a few questions, Nicole, that popped up in the Q&A. So do we want to go through a few of those?
Sure.
Perfect. Okay, well, let's just start from the top. So first question is, what about clinically using the client's guilt around how loved ones would feel if they died to reinforce this as a protective or safety factor?
Oh, this is a good question. I get this sometimes. I also get it around religious beliefs against suicide. And where people will say, you know, I wouldn't do it because I'll go to hell. And so people are like, should I use that? You know, if that's a protective factor, or is that, I don't want to be sounding like I'm damning someone to hell. So I think it's a slippery slope. If someone says, I wouldn't want to do that to my family, protective factor, I think you can use that. If the person is digging into their guilt so much that the guilt becomes a driver of the suicidality. So what I see sometimes is that clients who are prone to, like, I couldn't do that to my family because I couldn't live with myself for what the pain that it would cause them, are also the ones that say things like, I can't continue to create such a burden on my family, and that makes me feel guilty. So people who are motivated by guilt use it on both sides. So yes, protective factor, and you can use it. I would just have my radar up, or use it if they're using it. I would just have my radar up if they start really spiraling into that guilt, because they're going to turn it on its head and say, I'm causing my family so much pain already, and the guilt of that, they're going to be better off without me. So I just, you can use it sparingly.
Great. Okay. Next question. I want to be mindful of time here. So, I would love to hear any tips you may have on working with clients who feel quite attached to keeping the option of suicide open. For example, clients who are saying that they do not have a current plan to act, but are unwilling to get rid of their stash of pills or create a safety plan.
Yep. Yep. Well, because there's two parts to that question. So first of all, suicide is always an option. So many of our clients, if we try to take that away from them or pretend like it doesn't exist, it's first of all not accurate. It is an option. They always have it as an option. All of us have it as an option. Our goal in therapy is to create some other options in addition to that as an option. So I would not try to eliminate that as an option. With that being said, safety is another issue. So stashes of pills, means at home, whatever it may be, no. That, in creating safety planning, so that we can do this work, we have to have a safe environment. So making it, suicide can be an option, but carrying out steps toward the plan, which is keeping a stash of pills, impedes the work that is being done. Now, that doesn't mean I wouldn't say to someone, well, you've got a stash of pills, you can't see me until you get rid of the pills. Our first work would be around how can we create enough safety in the relationship, enough safety in the work that you feel safe enough to get rid of the pills, because the real work, the work that the healing work can't start until we get some safety at home.
Great. One more question here. When is an appropriate time in treatment to introduce the compassion letter writing intervention?
Oh, great question. I would not introduce it until you've gotten some buy-in around the concept of compassion. So I use Kristen Neff's work a lot of times with the 3 aspects of compassion of common humanity, self-kindness, and mindfulness. And so building some of that first before you do compassion letter writing, because it's going to be activating to them if you don't have that foundation first. So I'd want to have some of that in place where they have some buy-in to the concept of compassion.
Great, great. One more quick one that was thrown in the chat earlier. I saw, why wasn't the Columbia scale on your list?
Oh, great question. The Columbia is great. We use the Columbia.
Yeah.
It's an assessment of risk and not necessarily a measure of progress. So it will help us know if someone's low, moderate, elevated, but it takes a while to move through those risk levels. So it may mask progress, where some of those other questionnaires or assessments may give us a better picture, rather than the just those risk categories.
Yeah, great. All right. Well, we spent a few hours together. I hope everybody feels like this was really, really valuable. I know that I did, and we just appreciate you, Nicole, and all of your wisdom. So thank you for sharing with us. As we wrap it up, like I mentioned, we will be sending out a follow-up email, likely on Monday, Tuesday. It'll have the QR code, the link to presentation number 1. If for some reason you do not see it or you have other questions, You can always message us at hello@lightfully.com. I will drop it in the chat as well. And I hope you all have a wonderful Friday and a great weekend, and we will see you soon for our next presentation. So thank you all so much, and thank you again, Nicole.
Thank you.
Bye, guys.